Hi guys, welcome back everyone. I hope I'm audible to all of you and loud and clear. So we are continuing our video-based question series. We have already covered 2 videos on medicine and this is the third in the series. We have mostly addressed neuro videos. In this lesson, we'll try to address the videos that can be expected from cardiology. Okay. Now, let me take you through the first question. Just give me a thumbs up if I am visible to all of you. Okay, good. So here is the first question. A patient presented with shortness of breath on exertion and fatigue since 1 year. On examination, there is a mid-diastolic murmur that was heard in the fifth intercostal space. Okay, let me be more precise here. In the left fifth intercostal space. In the left fifth intercostal space. An echocardiography was done and the parasternal short axis view is given below. Identify the correct match of the diagnosis in this case and finding. But before I show you the video, can you make the diagnosis based on the question stem itself without looking at the video? Because most of the video based questions, already diagnosis will be evident from the other information given in the question stem. Video is in most cases an add-on. At least that is what we have observed in the recently concluded FMGE exam. So what do you think is the diagnosis here? Should I think of a left-sided heart disease or a right-sided heart disease? So typically the dyspnea is a symptom of left-sided heart disease. If you are thinking of cardiac disease, yes, there can be dyspnea because of respiratory disorders, systemic disorders like anemia and all. But if you are thinking of heart, we should primarily be thinking about left-sided cardiac condition. If I have raised JVP, hepatomegaly, ascites, these symptoms, then I would be thinking about right-sided cardiac condition. So now something must be wrong with the left side of the heart. Either LV failure, aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. These are the differentials I would think of, right? If you list the CVS causes for dyspnea, the main things that should be coming to your mind are mainly left ventricular failure, then AS and AR, MS and MR. Okay. Now you know the murmur. So from murmur also you can pick up the diagnosis. What we are getting a mid-diastolic murmur. And that too where? In the left fifth intercostal space. You know the left fifth intercostal space is actually the mitral area. So you are hearing a mid-diastolic murmur in mitral area. And you know where you get mid-diastolic murmur. Mid-diastolic murmur is heard in mitral stenosis and tricuspid stenosis. Already from the symptoms we know it is not a right-sided heart disease. Problem is in the left side of the heart and not in the right side. So I'm already leaning towards the diagnosis as mitral stenosis. Okay. Now let's see the video and see what echo findings we can get. Okay, this is not the video. Just give me a second. Let me pick up the right video. Okay, so this is the echocardiographic video. You don't have to bother as an undergraduate student about the different axes of echocardiographic view. There are only few key videos that you need to be aware of and we will be covering them for sure. So it shouldn't be a big deal at all. So what you see here, the round structure that you're seeing here is actually the left ventricle. Okay, and you can see this small round in the larger round, that's your mitral valve. That's your mitral valve. Okay, let me show you with a picture. You get better idea about this echocardiographic view and then we will discuss about the finding that we got. So in this particular echocardiographic view, just give me 1 second. One second guys, the image is not popping up as expected. Okay, I will show you here. So what you're seeing in the image is basically the round that you see is the left ventricle. What we have done is, okay, so if you imagine this as the left atrium, okay, this is your mitral valve. Below this you will have left ventricle like this. You will have left ventricle. We have taken a cut view here at this level. So when we take a cut view at this level, you will see left ventricle here, mitral valve is here and we have taken a slice there through the echocardiography. So you see mitral valve here and you know mitral valve is bicuspid. Okay. Now, normally what happens is, in normal physiological state, the mitral valve is quite large. The usual orifice when it is open is 4 to 6 centimeters square, and it opens completely. It opens completely. This leaflet goes in this direction, this goes in this, and it opens completely. But if it is stenosed, the mitral valve aperture becomes smaller, okay, and it is opening only little bit, not completely. This small opening creates the appearance of fish mouth. It creates the appearance of fish mouth. Probably if you see this video, you will be able to now understand. You're seeing this large round, which is the left ventricle, and what you see a small round in the middle of the large round is the mitral valve opening. Now it is not completely opening. It's opening only tiny little bit and closing. Don't you think it almost resembles the opening and closure of the fish mouth? Yes, so this finding is what we call as the fish mouth appearance. Image based questions have been already asked on the fish mouth appearance. Same thing, if I take a screenshot, that becomes your fish mouth appearance. Okay, and what we are getting here is the video of that fish mouth appearance. Okay, now I think I'll be able to give you a better picture because I got a screenshot. So this is your left ventricle. This is your mitral valve apparatus. Normally, mitral valve also will appear this big, because if this is a ventricle, this is where you have the mitral valve. Okay. So now that mitral valve opening has become small, in the center it is only opening little bit, creating that typical fish mouth appearance. So this is your mitral valve, this is your left ventricle, small opening, and this is what we are going to call as fish mouth appearance. So if they're asking you where do you get fish mouth appearance, the answer is mitral stenosis. In this question, they're asking you to match the finding and the diagnosis. So diagnosis we have arrived upon based on our clinical understanding. So we know it is mitral stenosis, and the echo finding is fish mouth appearance. Okay. Now let me take you to the next video based question. The following echocardiographic study is done for the diagnosis of which of the following condition? Okay, I will show you an echo video. You should notice what is being demonstrated there and then tell me it is done for which diagnosis. Whether a diagnosis is present in that echo or not, we will discuss that later. But first you should tell me for which diagnosis we use that echocardiography. Okay, just give me a second. 1 second. So you can see an echocardiography playing in front of you. What do you notice there? Do you guys notice that we are seeing two ventricles of the heart? And see, I'll show you the graphical representation of this echo and then we will try to interpret again. So what you're seeing here is these are two ventricles and this is where you're seeing two atrias. Okay, so this is your right atrium and this is right ventricle. This is left atrium and this is left ventricle. Okay, so what you notice, some blood or fluid enters the right ventricle first, and after some time you notice it entering the left ventricle. But what is characteristically apparent here is, does it look like the normal blood? Does it look like the normal blood entering the cardiac chambers? The answer is no. It looks like bubbly, right? It looks like some sparkling water, like cola bottle is shaken and then you get the sparkles. It looks like that. Do you agree? It looks like that sparkling or bubbling of the water. Yes, it is actually sparkling or bubbling of the water. So what we have done is, to get this echo done, we take a syringe. In that syringe, we take some saline and we agitate, means shake, to create air bubbles. So we agitate and create bubbles in that saline and then we inject it to one of the patient's vein. Okay, and after that we start doing the echocardiography and we want to trace this agitated saline or bubbly saline passing through heart. So we call this as bubble contrast echocardiography, or in simple words, bubble echocardiography. Okay, so what are we calling this echocardiography as? We are going to call it as The video that we have seen here is bubble contrast echocardiography. Now tell me, where do we do it? Bubble contrast echocardiography. Okay, so exactly what we do in bubble contrast echocardiography is we take a syringe which will have some agitated saline, means it will be having a lot of bubbles in it, and then we inject it into one of the peripheral veins. So once we inject this into one of the peripheral veins, mainly upper limb veins, so once we inject it into the upper limb veins, through the upper limb veins, it is eventually going to reach the superior vena cava, and then this bubbly fluid reaches the right atrium. From right atrium to right ventricle, from right ventricle, it will go to the lungs. And you know, lungs have pulmonary capillaries where gas exchange occurs. So once the bubbles reach the pulmonary capillaries at the site of gas exchange, this air that is there in the bubbled saline gets absorbed. These bubbles all will be absorbed. It generally doesn't reach the left side of the heart. You don't see the bubbles appearing in the left ventricle or left atrium. You can only see after injection that they will be appearing in the right atrium, right ventricle, and up to lungs. They won't go beyond that. But in two conditions, they will make their way into the left side of the heart. Now, what are those conditions? The first one is if you have these pulmonary capillaries dilated, well, what we can simply call as pulmonary vasodilatation. If there is pulmonary vasodilatation, then all these bubbles will pass through the dilated pulmonary capillaries and then get into the left side of the heart, and they will start appearing in the left ventricle. That's first condition, pulmonary vasodilatation. Second condition, if there is an intracardiac shunt, means there is a connection between two atria or there is a connection between two ventricles, then whatever bubbles that come to the heart, they will directly make their way into the left ventricle without having to pass through the pulmonary capillaries. In normal condition, if they reach the pulmonary capillary level, there will be absorption of these bubbles and they don't reach the left side of the heart. If there is pulmonary vasodilatation, they will reach the left side of the heart, or if there is an intracardiac shunt, these bubbles will reach the left side of the heart, right? So the study is called bubble contrast echocardiography, and it is done for diagnosis of number 1, intracardiac shunts like ASD, VSD, and VSD. Second, where do we get severe pulmonary vasodilatation? We get severe pulmonary vasodilatation in patients with hepatopulmonary syndrome. In fact, this investigation is considered as the gold standard for a diagnosis of hepatopulmonary syndrome. Now, some of you may be wondering, what is hepatopulmonary syndrome, right? So let me tell you what is hepatopulmonary syndrome. So if you have CLD or cirrhosis of liver, there will be production of large amount of vasodilatory substances. Now these vasodilatory substances, when they are dumped into the splanchnic circulation, means your superior mesenteric artery, inferior mesenteric artery, then splenic artery, portal vein, they become dilated. They hold a lot of blood, right? So because of the blood getting dumped into the splanchnic circulation, the effective circulating blood volume comes down, amount of blood going to the kidneys comes down, and kidneys lose functions. You call it as hepatorenal syndrome. Like whatever total 5.5 liters of blood you have, a large amount of it is dumped into the splanchnic vascular bed because of vasodilatation. So less blood is available for systemic circulation, less blood is going to kidneys, so kidneys lose function, you call it as hepatorenal syndrome. Similarly, these vasodilatory substances cause pulmonary capillary vasodilatation. And because of the pulmonary capillary vasodilatation, blood is getting pulled in the pulmonary capillaries, not getting transferred to the left side of the heart easily, creating hypoxia, right? So these vasodilatory substances can cause pulmonary vasodilatation, and that will result in hypoxia, and this condition is what we are going to call as hepatopulmonary syndrome. An important clue for the diagnosis of hepatopulmonary syndrome in a patient presenting with shortness of breath is something called as platypnea. Now, what is platypnea? We know orthopnea, we know trepopnea, What is platypnea? What is platypnea? Orthopnea is shortness of breath when you are in recumbent position or when you are lying down in supine position. But if opposite of it happens, like in orthopnea, when you lie down, you feel short of breath. When you make yourself upright, the shortness of breath gets relieved. But here, opposite of it. When I lie down, I feel relieved. When I'm upright, I feel more short of breath. It is called as platypnea. So if you get a patient with known alcoholic cirrhosis, now having platypnea and hypoxia, that's the clinical clue for diagnosis of hepatopulmonary syndrome. On top of that, if they ask you what is the gold standard for diagnosis, then the gold standard for diagnosis is going to be bubble contrast echocardiography. Bubble contrast echocardiography is the gold standard for diagnosis of hepatopulmonary syndrome. Now, how this investigation actually helps us to diagnose is because if there is pulmonary vasodilatation, the bubbles that we injected through the agitated saline will be able to cross the lungs and reach the left side of the heart. Okay. But if there is no pulmonary vasodilatation, they will be absorbed in the pulmonary capillary level itself and they will not reach the left side of the heart. Okay. Now, the next question is, can I differentiate between these two conditions that I have listed here, intracardiac shunts and hepatopulmonary syndrome? Yes, what we do is, once we inject, we first look for the appearance of these bubbles in the right side of the heart. Once they appear in the right side of the heart, how many cardiac cycles it takes for these bubbles to appear in the left side of the heart? If they appear in the left side of the heart within 3 cardiac cycles, like okay, it came here, I saw here, and then within 3 contractions, the bubbles are also visible in the left side of the heart, then it means there is an intracardiac shunt. ASD or VSD should be there. But if it takes more than 3 cardiac cycles, usually 5 to 6 cardiac cycles it takes for these bubbles to appear in the left side of the heart, then these bubbles have to pass through the pulmonary capillaries and then reach the left side of the heart. In that case, it indicates that you have hepatopulmonary syndrome, right? So now I will play the video again and you should tell me whether in this case I should be suspecting hepatopulmonary syndrome or I should be suspecting ASD, VSD in the video. Okay, so here in case of intracardiac shunt, bubbles appear in LV in less than 3 cardiac cycles. After they appeared in the right ventricle, they appear within 3 cardiac cycles into the left ventricle. But in case of hepatopulmonary syndrome, bubbles appear between 4 to 6 cardiac cycle. Appear into LV within 4 to 6 cardiac cycle. Okay, now let me play the video again and now you should tell me what should be my diagnosis here. I should be suspecting an intracardiac shunt or now you saw the bubbles appearing in the right ventricle and then within the next cardiac cycle itself the bubbles appeared in the left side of the heart as well. Means they did not take more than 3 cardiac cycles. Do you notice? Once it goes to the right, the next cycle itself it makes the way into the left. So the bubbles appeared within 3 cycles to the left. That means we are thinking about intracardiac shunts. In this case, probably atrial septal defect. Okay, but if they had appeared, okay, once it go into the right, next cycle nothing is there on the left, next cycle no, next cycle no, 4th, 5th or 6th cycle I start seeing the bubbles in the left, then I would have taken it as hepatopulmonary syndrome. Clear? So the video we saw shows intracardiac shunt. But question is asking, this investigation is done for diagnosis of which of the following conditions? So among the given options, only thing that makes sense is to choose hepatopulmonary syndrome, right? I'm not going ahead with any other condition. Okay. Now let's go to the next video based question. A patient was brought to ER with road traffic accident in a state of shock. BP on arrival is 60/40. Echocardiography revealed following findings. Which of the following is true about the condition? Let us look at the history first. Someone has gone through road traffic accident and after that he has been brought to the emergency room and he is in a state of shock, and all I notice is his BP is quite low, right? 60 by 40 millimeters of mercury. Now let's see what the echo video is going to show us? What is the echo video showing us? What do you notice in this echo video? Jayalakshmi Iyer, absolutely right. Yes. What's the diagnosis and what heart is doing? Heart is literally dancing like that Hrithik Roshan's song in Koi Mil Gaya. Kabhi idhar chala, kabhi udhar chala. It's literally behaving like that. It is swinging like a pendulum. But inside what it is swinging like a pendulum? So the video we saw here is actually showing a heart having pendular motion. Heart with pendular motion. And surrounding the heart, what do you notice? All that dark you see surrounding the heart is nothing but pericardial fluid. So cardiac muscle is visible as white, while the fluid is visible as black. So surrounding the heart, what you see in black is fluid. That is fluid. And what you see inside the heart, because inside the heart is again blood, so that is going to be fluid, so that is dark. So you see heart with pendular motion in pericardial fluid. In pericardial fluid. The story is there: road traffic accident, shock, hypotension, and you see echocardiography showing large amount of pericardial fluid and heart is swinging inside it. So then what is the diagnosis? Yes, the diagnosis is cardiac tamponade. Cardiac tamponade. So what is cardiac tamponade? So basically when you have massive pericardial collection of fluid, this fluid can compress the cardiac chambers. So if I bleed profusely, or if for some other reason I accumulate a large amount of fluid in the pericardial cavity, of course accumulation of fluid will start increasing the pericardial pressure. So this fluid will start compressing the cardiac chambers. They will start exerting the pressure on the heart and they will start try to compress the cardiac chambers. Now under this pressure, the cardiac chambers can collapse. Which ventricle is likely to collapse first? Right ventricle or left ventricle? See, as of now, if I start accumulating the fluid in the pericardial space, I will simply call it as pericardial effusion. It is not cardiac tamponade yet. It is not cardiac tamponade yet. This is basically pericardial effusion. Okay, you developed pericardial effusion. It is now compressing the cardiac chambers. Usually, right ventricle falls first. Reason is simple. If you have dissected the heart and seen, left ventricle is more muscular because left ventricle is contracting more to generate strong force to deliver the blood to every part of the body. Right ventricle job is to push to the lungs. So it is doing less work. Less work means less muscle mass. So if I have to put pressure and compress something, it is more easier to compress someone with less muscle mass than someone with more muscle mass. So under the pericardial fluid buildup, generally the right ventricle collapses first. And once the right ventricle collapses, I'll start calling this as cardiac tamponade. So under this fluid pressure, the right ventricle is collapsing first. So now I have a collapsed right ventricle. At this point of time, I will end up with hemodynamic consequences, and then I will call this as cardiac tamponade. Why will I get hemodynamic consequences? Number one, the right ventricle is collapsed. So when I try to fill the blood into the RV, I will not be able to fill sufficiently because it is a collapsed ventricle. Almost barely any passive filling occurs. Whatever we do is only little bit of active filling. So RV filling will be reduced if right ventricular filling is reduced. Now if RV filling is reduced, the amount of blood that goes to the lung will also be reduced because I gave less blood to the right ventricle, less blood goes to the lungs. If less blood goes to the lungs, less blood comes to the left atrium. If less blood comes to the left atrium, less blood comes to the LV. So indirectly, whenever RV filling is reduced, LV filling is reduced. So if LV has less blood to eject, it will eject less blood. So indirectly, your stroke volume will come down. And your systolic BP is going to be directly proportionate to stroke volume. Basic physiology. The more blood I eject into the aorta, more systolic BP I get. If stroke volume decrease, systolic BP decrease. So now you got hemodynamically compromised patient because of the reduced RV filling. And this is why you get hypotension as part of Beck's triad in cardiac tamponade, because RV filling is reduced. Indirectly, that leads to decreased LV filling, reduced stroke volume, reduced systolic BP. Okay. Second thing, if you're not able to transfer blood to the RV because RV is collapsed, pressure in the right atrium starts increasing, so that leads to increased JVP. Increased JVP. Okay, so if you get increased JVP, it indicates RA pressure is high. Again, it means RA is not able to pass on the blood to the RV. Indirectly, it tells that you have collapsed right ventricle, right? Okay, so med school grad, a very good question. So merely presence of fluid will not qualify to be called as cardiac tamponade. To call it as cardiac tamponade on the echocardiography, we need three things. One, there should be pericardial effusion or fluid present. Second, your right ventricle should be getting collapsed during the diastole. Systole anyway it contracts, so we can't see whether it is collapsed or not, because anyway it's going to become small, but during diastole it appears collapsed. That's the second thing. Third, on the echocardiography, you can get the evidence of raised right atrial pressure by looking at the inferior vena cava. So if the right atrial pressure is high, inferior vena cava becomes dilated. So these three things together make up for the diagnosis of cardiac tamponade on echocardiography. But if I don't get a collapsed right ventricle, and if I don't get the dilated inferior vena cava, I only see fluid in the pericardial space, then we will call it as pericardial effusion. There is no cardiac tamponade yet. If more fluid accumulates, yes, it might lead to cardiac tamponade. In fact, we call this as the echo triad of cardiac tamponade. These three findings: pericardial effusion, collapsed RV, and dilated inferior vena cava. So echo triad of cardiac tamponade. The first one is pericardial fluid. Second, diastolic RV collapse. And third, dilated inferior vena cava. We do have a clinical triad of cardiac tamponade. What is the clinical triad of cardiac tamponade? Yeah, you call it as Beck's triad. You call it as Beck's triad. So what are you getting in Beck's triad? You will have raised JVP as the first finding. Second, you will have hypotension. So now you know why you are getting raised JVP, because RV is collapsed. You are not able to transfer blood to RV. It is staying in the RA. RA pressure is going up, so JVP is getting raised. Inferior vena cava pressure is also getting raised. Inferior vena cava pressure rising is evident as dilatation on echocardiography. I cannot directly see the inferior vena cava, but pressure buildup in the superior vena cava will reflect on the JVP. Hypotension because collapsed RV, decreased RV filling, decreased LV filling, decreased stroke volume. Third, fluid is not a good conductor of sound. So when you keep a stethoscope here and try to auscultate, the cardiac sounds will be heard as very distant because fluid is muffling the sounds. So we'll call it as muffled heart sounds. Muffled heart sounds. So we have a clinical triad, we have an echo triad. Most cases of cardiac tamponade are recognized on the clinical basis itself. Echo just confirms your clinical diagnosis. Okay, you do have an ECG triad as well. ECG triad of cardiac tamponade. So now what is this ECG triad of cardiac tamponade? Number one, whenever your BP goes low, for whatever reason, if you have hypotension, there will be activation of sympathetic nervous system, means adrenaline, noradrenaline, dopamine, they are all pumped into your circulation, and though they will of course increase the force of contraction of the LV, they will exert the inotropic effect, but they are also chronotropic, they will increase the heart rate as well. So you will see any patient with hypotension, not only the cardiac tamponade, any patient with hypotension will generally have tachycardia, and it is going to be sinus. So sinus tachycardia will be observed. Second, when we place an electrode on the surface of the chest to record ECG, whatever electrical impulse that is coming from the heart to the surface, the voltage gets diffused or reduced by the fluid. So the entire voltage will not reach your surface electrodes. So the amplitude of the QRS complexes starts becoming small. So you will have low QRS amplitude. On top of that, this heart can now start swinging inside this pericardial fluid, and when it starts swinging inside the pericardial fluid, sometimes the heart comes closer to the surface electrode where we have placed electrode for recording the ECG, and sometimes it goes away, like you have seen in this video, right? In this video, you have seen that it is swinging. So sometimes it is coming closer to the surface, sometimes it is going away. So whenever it comes closer to the surface, there is less fluid between heart and the electrode. So you record a better voltage. When it goes away, between the heart and the ECG electrode, there is more fluid. So the voltage gets reduced and you get a lower QRS voltage. So you end up seeing an ECG where one complex is large because that time the heart was more closer to the surface, and another next complex will be small because the heart is moving away from the surface, and we will call that as electrical alternance. Electrical alternance. So these three things put together are called as, so electrical alternance looks like this. One QRS complex which is relatively small because heart was away from the surface electrode, then next one relatively large, next one again small, the next one relatively large. So this is how the QRS complexes are going to look like, and we call it as electrical alternance. Okay, so now that basics are clear, let's see if we can answer the question. Yes, the diagnosis is done. We are talking about cardiac tamponade because we saw that pendular motion of the heart inside the pericardial fluid. Which of the following is true about the condition? So if you are talking about cardiac tamponade, first thing is the most common cause for cardiac tamponade is indeed trauma. And when trauma occurs, why did I get fluid in the pericardial space? It's not because of increased oncotake or decreased oncotake or increased hydrostatic pressure, because trauma will not suddenly decrease your oncotic pressure or increase the hydrostatic pressure. Trauma can introduce blood into the pericardial space. So basically you can say traumatic hemopericardium is the most common cause. More than 90% of the patients of cardiac tamponade that you see in your clinical practice will be because of trauma leading to bleeding into the pericardial space. Okay, so now let's try to answer. ECG may show electrical alternance. Yes, we saw the pendular motion, so it indicates that heart is coming closer to the surface and going away, so you can get electrical alternance. Hemopericardium is the most common cause. That's also true, and we do get muffled heart sound in cardiac tamponade, so this is also true. So that means all of the above becomes our correct answer. Okay. Okay, now let's go to the next question. A female patient aged 52 years started complaining of sudden onset pain. Okay, chest pain after hearing her son's NEET paper leak. ECG showed non-specific STT changes and troponin I was mildly elevated. Echocardiography video is provided below. What is the likely diagnosis? Okay, now before going to the echo, tell me what are the differential diagnoses you are thinking of for this condition. Let me remind you, we are talking about a female patient here. She is age 52 and she started complaining of sudden onset chest pain. And this chest pain was precipitated by the news that her son, who was given NEET paper exam, the paper was leaked. Maybe she was aware of the previous year's NEET paper leak and whatever hardships the previous batch of students had gone through. So if there is another leak, this could be quite a shocker for her. She is probably worried about her son, and now she has developed sudden onset chest pain. Can this be a case of MI? Yes, MI is also possible because myocardial infarction can be precipitated by vagal activities like sudden vagal surge. So MI is a possibility. Another possibility is stress cardiomyopathy or Takotsubo cardiomyopathy. So for me now differential diagnoses are two. One is myocardial infarction. Second one is stress cardiomyopathy or Takotsubo cardiomyopathy. Okay, so now tell me, in what way echo can be useful? What do I get on echocardiography if I indeed have MI? And what do I get on echocardiography if I have stress cardiomyopathy? Stress cardiomyopathy is also called as Takotsubo cardiomyopathy. Does the ECG rule out MI here? No. Remember, ST elevation, the very specific type of ST elevation, is encountered in STEMI patients, but there is also a category of MI called non-ST elevation MI where you may get some non-specific changes. You need not get the typical ST elevation, but still you will have subendocardial infarction. or patient may be at the unstable angina stage now, and that's why you are not seeing anything on the ECG, but if time progresses, he will end up with ST elevation MI. Possibilities are there. So a normal ECG or non-specific ECG changes does not rule out MI. Mild elevation in troponin I can be pointed towards MI. So MI is still my differential diagnosis. So like if you get such a story in the exam that a stressful event has precipitated, mostly examiner is talking about stress cardiomyopathy, but MI is still an important differential diagnosis. Okay. Now let me tell you what you can get in the MI. In the MI on echocardiography, you will see what is called as regional wall motion abnormalities. Regional wall motion abnormalities. What do I mean by that? Well, the regional wall motion abnormality basically refers to, let us say I have developed a lateral wall MI. Okay, so this is my heart, this is my interventricular septum. Okay, so that, let us say that this is the lateral wall. I'm just telling you to consider this as the lateral wall, this as interventricular septum. And if I have developed lateral wall MI, that means part of this lateral wall is infarcted or dead. Now, do you think that infarcted part of the heart will be able to participate in the contraction? No, it's dead muscle. How can it contract, right? So you will notice that this part of the ventricle in the cardiac cycle, it's not contracting. The remaining part is, this is contracting, interventricular septum is contracting, right ventricle is contracting, but the lateral wall, the part that is infarcted, is not participating in the contraction. It is just kind of stagnant. Such findings we call as regional, because only affected region is showing reduced mobility, right? Regional wall motion abnormalities. If there is an MI, you will see regional wall motion abnormalities. If I have inferior wall MI, the inferior wall will show reduced contractions during the systole. If I have septal MI, septum will show reduced contraction. That's what you get in case of MI. What do you get in case of stress cardiomyopathy? In stress cardiomyopathy, you will notice that two things you can identify on the echocardiography if it is stress cardiomyopathy. Okay, the first thing you can notice in case of stress cardiomyopathy is the shape of the ventricle becomes what you call as Takotsubo shape, the Japanese octopus trap shape, or Takotsubo shaped left ventricle. And in that shape, one thing you notice is during the systole, the apex pouches out like a balloon instead of contracting. So you will notice apical ballooning, apical ballooning. So these are the two findings you can notice in case of stress cardiomyopathy or Takotsubo cardiomyopathy. What echo findings I can get in case of hypertrophic obstructive cardiomyopathy? First thing is shape of the ventricle. You will have a banana shaped left ventricle. Banana shaped left ventricle. Second thing you notice is there is something called as SAM. SAM stands for systolic anterior motion of anterior mitral leaflet. Okay, that I will show an echo in one more class about the HOCM also. So these are important findings that you should be aware. And you can also notice that the ejection fraction often in the initial stages is increased. Okay, so now let me play the video that we are supposed to see. So the larger chamber that you see on the top, right, somewhere here, okay, that's going to be the left ventricle. Okay, and below what you see is the left atrium. Okay, and then what you see here is the, on the little far that side, that's going to be right atrium, and then top that is the right ventricle. So what do I notice here? The right ventricle is contracting well, right atrium is contracting well, left atrium is contracting well. When I look at the left ventricle, the tip of the left ventricle is not contracting, apex. Okay, but the part of the left ventricle which is connected to the left atrium, that is contracting well. So what is this? Say 1, 2, 3, 4, 6. Yes, absolutely right. If you are still in doubt, if you are not able to differentiate between MI and stress cardiomyopathy on the basis of clinical grounds and echocardiography, certainly we have to go ahead with the coronary angiography. Coronary angiography will turn out to be normal if it is stress cardiomyopathy, and if it is MI, of course, whichever blood vessel is affected, it will show the stenosis or obstruction. Okay, so basically what happens in case of stress cardiomyopathies, in MI you are getting regional wall motion abnormalities. In case of stress cardiomyopathy, whenever you hear a stressful news, especially if it is too sudden, there will be release of extreme amounts of catecholamines like adrenaline, noradrenaline, dopamine. And what do they do? If I'm looking at the left side of the heart, let us say this is right side of the heart, okay, and this is going to be my left side of the heart, okay. So left ventricle is more or less like a cone, okay, it's a little conical, and this is where your aorta is originating, okay, and this is your aorta, and this is where you have the left ventricle, sorry, left atrium. So this is going to be my left atrium, this is left ventricle, okay. Now this left ventricle has parts. What are the parts? Okay, now this is mitral valve, this is aortic valve, we know. Now this left ventricle, this tip we will call it as apex, okay, and this part of the left ventricle, in which that area which receives the blood from the left atrium coming into the left ventricle, I will call this part as the left ventricular inflow tract. This part we will call it as left ventricular inflow tract, because blood comes into the left ventricle from this region, okay. And then this part of the left ventricle where blood actually leaves the LV to go into the aorta, we will call it as left ventricular outflow tract. We will call it as left ventricular outflow tract. So this will be my left ventricular outflow tract. And this tip of the left ventricle that we see here, this part, this tip, I will call it as apex. This is going to be your left ventricular apex. Now what happens in stress cardiomyopathy is you have a lot of adrenaline, noradrenaline and everything coming and stimulating the ventricle. But you see the maximum stimulation at the level of left ventricular outflow tract. So because of that, this portion contracts aggressively and this portion doesn't contract much. So that results in the shape of the ventricle changing somewhat like this. Let me use a color that we can. This portion contracts aggressively. Just give me 1 second. So this portion is contracting aggressively here, and this portion is not able to contract much. So now what happens? Whenever ventricle wants to push the blood to the aorta, because of the intense contraction of the muscles in the left ventricular outflow tract, this becomes narrowed. So blood cannot escape out easily. But because the apex is not contracting much, the pressure is now directed towards the apex. So apex dilates. Instead of being conical earlier, it becomes more dilated like this. And because here the muscles are contracting, it becomes narrowed. And now it creates the shape of the ventricle, which looks like the Japanese octopus trap. Japanese used to use a trap to catch hold of the octopus, and then they could like make delicacies out of it. Because now the ventricle resembles like that, they call it as Takotsubo cardiomyopathy. Okay, and when you do an echocardiography and see, you will see that this portion is contracting because this is being hyperstimulated by adrenaline, noradrenaline, but this you see that it is not going to be contracting. So in this echocardiography that we see, exactly that is what we notice. The left ventricular outflow tract is contracting. Okay, if you're not able to understand, let me screenshot it and label it so that you can understand the picture, the echo orientation well. So in this echo, this is your left ventricle. This is your left ventricle. This is your left ventricle. Okay, and this is your left atrium. This is your right atrium, and this is what you see here is your right ventricle. Okay, now this portion is exactly what I called as left ventricular outflow tract. This is your left ventricular outflow tract, and this portion is your apex. This is your apex. So what you notice here, the outflow tract is contracted, it is narrow, but the apex is not contracting. Normally LV should be conical in shape like this, but here it is dilated. It now looks like the balloon, and the whole ventricle looks like the octopus trap, the Japanese octopus trap. So here you are noticing what is called as apical ballooning. That is what you called as apical ballooning. It's almost like the shape of the balloon, right? And overall, if you see the ventricle, apex is like balloon, overall ventricle now resembles the Japanese octopus trap. So this is apex, and this is left ventricular outflow tract, which is narrowed. And this phenomenon, we call it as Takotsubo cardiomyopathy or stress cardiomyopathy. So findings we are getting here is apical ballooning and Takotsubo shaped left ventricle. And in this shape, basically two things are there. One is left ventricular outflow tract narrowing. Second is apical ballooning. Both put together, you are getting the shape of the ventricle that resembles Takotsubo. Okay, so the diagnosis became clear. What we saw here is stress cardiomyopathy or Takotsubo cardiomyopathy. So echo made it clear. So probably I don't have to go for the coronary angiography. If I'm uncertain, I will go ahead with coronary angiography to ensure that what I'm dealing here is not a case of MI. Now tell me, how do we manage a case of stress cardiomyopathy? Main thing is you're not able to contract the apex. You're not able to generate sufficient cardiac output. So patients will end up with hypotension. Patients will end up with hypotension. And to improve the BP, we do a procedure called as intra-aortic balloon pump. So we basically put a balloon inside the aorta, which acts as which inflates and deflates. So when we do that, one thing we notice, see, why are we getting this kind of heart failure kind of picture in stress cardiomyopathy? Because when too much of adrenaline, noradrenaline bombard the heart, they hyperstimulate the heart. For a transient period, heart contracts very vigorously. But after contracting vigorously, it spends all its metabolic reserve, means whatever ATP is, glucose, whatever reserve it had that is used for energy generation is all used up. And it doesn't have the metabolic reserve now. That's why it stops contracting, or it reduces its contracting ability. That's why it is not contracting well. It is in a stunned state. Now, if the heart has to contract efficiently again, it needs to get the nutrients. It needs oxygen, it needs glucose, it needs other cofactors required for the ATP production. But the problem is, once heart is not contracting well, it is not going to receive the blood well, because the myocardium gets the blood supply from coronary arteries, which originate from the aorta. So if heart pushes the blood to aorta, then it gets the blood. If heart itself is not pushing the blood to the aorta, then coronaries also won't get the blood flow. So now you are stuck in a situation. Heart is not able to contract, so it's not able to push the blood to aorta. So if you're not able to push the blood to aorta, you will not get the coronary flow. If you're not getting the coronary flow, then how will the heart regain its contractility? So you're in a vicious cycle. So to break this cycle, what we do is, we do something called as intra-aortic balloon pump. So we pass a catheter into the aorta, and the tip will have a balloon. Now this balloon inflates during diastole and deflates during systole. Now you might ask, sir, how does it help the heart? So if I inflate it during the diastole, pressure inside the aorta starts increasing because we are blocking the forward flow of blood. So inside the aorta, pressure is going up. So this pressure build up actually pushes more blood to go into the coronaries, and now you will be able to deliver more blood to the myocardium. And once you start delivering the blood to myocardium, it gets glucose, it gets oxygen and other cofactors, it starts making ATPs, and slowly it regains its contracting ability. Now you might be wondering, sir, but if I put a balloon into the aorta and inflate it, don't you think I am compromising on the blood flow to different body parts? Well, we are not compromising much here, because this balloon actually inflates during diastole, but during systole it deflates. So systolic forward flow of blood is not affected. Now, how does it actually help? Well, simple thing is, according to what we studied in physiology, the coronary flow mainly occurs during diastole, because coronaries are literally embedded into the myocardium. So when heart contracts during systole, they are squeezing the coronaries. So blood flow cannot occur during systole through coronaries. Coronaries blood flow only occurs during diastole. But your body parts receive the main flow during systole. So if I inflate the balloon during diastole, then I'm building up the pressure in the aorta, and that is helping me to increase the flow through the coronaries during diastole. And as soon as I enter into the systole, I deflate it, so I am not compromising on the blood flow to the organs as well. Right? So this is the treatment that is generally followed when you end up with hemodynamic compromise if you have stress cardiomyopathy. Let me tell you, we cannot use the inotropic agents to increase the BP here. We have to go ahead with intra-aortic balloon pump only. Why I cannot use inotropic agents? Because most of your inotropic agents are catecholaminergic drugs, right? Same things you use, noradrenaline, dopamine, to increase the BP. But the same things have caused the problem here. They have hyperstimulated the heart. They have made heart spend all its energy reserve, and you give more catecholamines, they will cause more left ventricular outflow tract obstruction, more apical ballooning, and they will worsen the situation, right? So catecholaminergic inotropic agents are contraindicated in case of stress cardiomyopathy. Okay, so that's it from me today. So we have learned about 4 important videos from the cardiology. Let me just quickly recap for those who have joined late. The first one was a patient with left-sided heart symptoms, mainly dyspnea. We had thought of these conditions as differential diagnosis, and then the story had mentioned a mid-diastolic murmur. So from mid-diastolic murmur, we know it occurs in MS and TS. And because the symptoms were predominantly left-sided, clinically we had concluded that we are dealing with MS, and then we had seen a video. And what video had shown us? Video had shown us what we call as fish mouth appearance. Narrow opening of the mitral valve, creating the appearance of the opening and closure of the fish mouth. So that was the first video, typical of mitral stenosis. Image-based questions have already appeared. In the second question, we saw a bubble contrast echocardiography. The video resembled this. One second. This is the video we had seen for the second question, and we had asked for what diagnosis we use it. So here we have injected saline which is agitated to create bubbles, and then we are seeing the delivery of this bubbly fluid into heart's chambers. We call it as bubble contrast echocardiography. We do that for diagnosis of 2 conditions, intracardiac shunts and hepatopulmonary syndrome. Okay. The next video we had seen was for this question. Here we had seen a patient with his heart literally floating like a pendulum. Give me 1 second. Floating like a pendulum inside the pericardial fluid, indicating pericardial effusion. And with the context that we had in the question, that road traffic accident, state-like shock, so we think of it as cardiac tamponade. Okay. The other video we just saw, that was about stress cardiomyopathy, showing the balloon-shaped apex, contracted left ventricular outflow tract, creating the Takotsubo shaped left ventricle. Okay, so that's it from me today. I'll see you in the next class. Till then, have a good time. If you want to practice more video-based questions, the PW Meded already has video-based grand tests available on the app, and the PDF will have the details about enrollment and taking the test. So if you want, you can go through that. So I'll see you in the next class. Till then, have a good time, guys. Bye-bye.